I've been coughing and wheezing for 2 weeks. Okay? Differential here is enormous. So I want to get some more information before I do anything. If this is CSA, I'm not going to rush to start ordering all kinds of exotic tests now. I need some more information. Again, is this just from the first line? Do you suspect this is going to be a very acute patient or a more stable patient? Is this an acute, emergent patient or a more chronic, more stable patient? 2 weeks, I'd say it's in a chronic, stable situation. I could afford the time it takes to get a little more information on the CSA. So this is a 20-year-old college student who comes to the emergency department with a 2-week history of increasing cough associated with intermittent wheezing. Well, 20-year-olds, what's the most likely thing he has? Do we know it's a he? Is it a he? Whatever. He, she, what's the most likely reason they're coughing and wheezing for 2 weeks? 20-year-olds? Maybe just plain old asthma. All right, couple weeks. Maybe the patient would generally come a little sooner, but plenty of patients, especially they're busy, stay home only when it gets bad enough that they come to the doctor. Could this be a pneumonia? Coughing and wheezing, could it be an atypical pneumonia in the community? Sure. They live in a college. Could it be one of the atypicals like mycoplasma pneumonia? Sure. All right? But let's go on and get some more information. The cough was initially dry. That's typical for atypical pneumonias. Typical for atypical pneumonias. Or typical for wheezing. Dry, non-productive cough for wheezing. For asthma. But it's become productive and yellow in color over the past few days. Okay. Not typical of asthma. Not typical for an atypical pneumonia. She has a low-grade fever since yesterday, but denies chills, chest pain, and hemoptysis. Okay? Low-grade fever. Do we usually see that with asthma? No. Do I usually see it with atypical pneumonias? Yes. So still very likely the time course for an atypical pneumonia is 2 weeks about right? Yeah. Most atypical pneumonias, why do we call them atypical? Well, because the old-fashioned typical pneumonia comes on acutely, within a few hours. Patient has a fever, the classic presentation of pneumonia. Patient has a fever with a rigor, starts having cough, maybe pleuritic chest pain. It's an acute process. Within a day, they have a full-blown pneumonia picture. Whereas in the atypical patients, it's atypical in the sense that it could take days or weeks till the patient has their full-blown syndrome. Pneumonia, typical pneumonias have a productive sputum. Atypical pneumonias tends to be a dry, non-productive cough. A typical pneumonia tends to be a lobar consolidation. An atypical pneumonia, more of interstitial, maybe diffuse, maybe bilateral pattern on the chest x-ray. But it's atypical in that there's no single lobar area of consolidation. Okay. Let's go back to our patient. She's in excellent health, except for a left ankle sprain that she sustained when she fell at a fraternity party last month. Do people who fall and injure their ankles have any pulmonary symptoms associated with that? Could she have thrown a fat embolism? That's an interesting one. Just made that one up. Fat embolism. Trauma, pulmonary symptoms. What doesn't fit with fat embolism? Fat embolism, who does get it? People who fall and sustain trauma. Is it usually someone who trips and sprains an ankle? Or is it someone who's in a motor vehicle accident and breaks every large bone in their body? That's a lot more common. Their bone breaks open, the marrow is corrupted, fat escapes from the marrow, gets into the bloodstream, and goes to different places. To the skin, gives you petechiae, to the brain, change in mental status, to the lungs, and gives you acute fatty pulmonary embolus. But that's an acute process in a very sick patient with major trauma. All right? Not this pathetic little ankle sprain. All right? She admits to having drunk too much beer that night. Oh. And even broke part of a tooth in the fall. Oh. This is more trauma than I thought. She broke a tooth. So she had a fat embolism from her tooth. Maybe that's her big bony break. I don't think so. I don't think so. She otherwise denies significant past medical history and is not taking any medications. But what else did I just discover in that sentence? Oh, she was drunk. Change in mental status. Oh, change in mental status, pulmonary process. Shall we think of aspiration pneumonia? What is wrong for the diagnosis of aspiration pneumonia for this patient? If at lunch today, between cases, I go out as I usually do and get drunk so I could come back and tape some more in the afternoon, and I aspirate when I fall down as I leave here this evening, okay? When will I get sick? Will I get sick 2 weeks from now? No. Why will I get sick? Because I've aspirated oral flora. anaerobes, all right? Your mouth is a sewer. Maybe not your mouth. My mouth is a sewer. There's all kinds of anaerobes, gram-negatives, gram-positives. And that gets into the lungs in a big way, okay, because I don't usually aspirate because I'm an alert person some of the time. I have an intact gag reflex, so I don't aspirate oral secretions all the time. But if I get drunk, I lose my gag reflex, I aspirate large volume of oral bacteria, I get an aspiration pneumonia. When? 2 weeks? No, within the day, 2 days tops. And I'll be quite sick. I'll have a high fever, maybe some rigors, localized findings on chest X-ray from my anaerobic lung infection. This patient, if she came in the day after this wild party of hers with this major trauma to teeth, ankle, I mean, she's a wreck, and she has a fever of 102, would I suspect aspiration pneumonia then? Sure, all right? But 2 weeks later, it's way too long for an aspiration pneumonia to go on. All right? So let's go on. So what else is maybe coming to mind? Coughing and wheezing. I haven't heard anything yet about a history of asthma. She fell, broke a tooth around the time when she was drunk. All right? Change in mental status and a broken tooth. Vital signs: low-grade temperature, normal blood pressure, on the mildly tachycardic side. Respiratory rate is 20. She appears well-nourished and no acute distress. An acute aspiration anaerobic pneumonia. Patient look acutely ill, or do they look like they just walked in and happened to have a little bit of a cough, so they thought they'd stop by and ruin your day? Which one? Acute. They're sick. All right? This patient, you're not being told of an acute sick patient here. Examination of the mouth shows a broken premolar on the left upper side. Otherwise, she has good dentition. So is this someone who's used to having teeth broken all over? Is this an alcoholic who's lost most of their teeth, has a lot of gum disease and abscesses in the mouth? Am I worried about that sort of thing in this sort of patient? No. A few wheezes are heard over the right lung base. Localized wheezing. Does asthma cause localized wheezing? No. Does a pneumonia, can a pneumonia cause localized wheezing? Yes. But does this patient have a pneumonia that's going on for 2 weeks? Not quite, certainly not a typical pneumonia. Could this be an atypical pneumonia? It can, but I'm getting a flavor for other things going on too. Examination of extremity show a left ankle and support bandage with no edema. Neurovascular examination is intact, also with no edema. So what should I be thinking of? What would be the first diagnostic step? Let me rephrase that. What would be the next step in the management of this patient on your CSA? I hear a lot of murmuring about chest X-ray. Sounds good. How about putting in an IV? Hey, after all, you're in the emergency room. How hard is it to stick an IV in? She has a little bit of a fever. Do you need a... Nah. I would say that's a -1. Why stick an IV in? This patient is not dehydrated, not hemodynamically unstable. -1. All right? If you put in a big IV, I'll give you -3. All right? Chest X-ray, +5. Test of choice right here. Because even if I don't know the diagnosis, I know she has a focal process. I have a focal process, let me take a look at that focal area. All right? And what am I thinking about? Something happened 2 weeks ago. She broke a tooth while she had a change in mental status. Where is that tooth now? Probably not in the dentist office, not in the garbage can at home, but probably at the right lower lobe. And if I do a chest X-ray, I will see that. That's radio opaque. I will see that on my X-ray. And I'll probably see some increased interstitial markings or maybe some lobar consolidation there. After all, she's entitled to have a pneumonia just like someone who has a bronchial obstruction from a carcinoma. This thing's been there 2 weeks. And it started causing symptoms. Soon after she fell, after she was drunk, got in there, initially didn't have much obstructive symptoms, but now probably has a post-obstructive pneummonia. Okay? So foreign body aspiration. Why did I not immediately think of a aspiration of a foreign body in this person? Because this isn't a typo. She's a 20-year-old college student. She's not a 2-year-old college student. 2-year-old with an acute pulmonary event, I think about foreign body aspiration instantly. I mean, how many 20-year-olds have things swallowed that end up in their lungs? It's not common, except you're given a situation with a change in mental status, and all kinds of funny things happen with change in mental status at fraternity parties where you're drinking too much beer. Okay? So foreign body aspiration. In this case, obviously, what will show up on her chest X-ray? Her tooth. All right? What will I do with that patient? Do I call in a dentist? see a little cavity on the film. After all, you go to the dentist, they do x-rays too. You say, well, I think there's a little cavity in here. Maybe we should fill it. Is that what you're going to do? No. -5. Call the dentist, -5. All right? What I need to do is relieve this patient's problem. What is this patient's problem? Pneumonia. Am I going to give this patient antibiotics as my next step? Yeah, I could do that. Yeah, it's a reasonable thing to do. She has a low-grade fever, and she presumably has a post-obstructive pneumonia. If I said I'll give her antibiotics next, maybe I'll pick up a point. Because there's nothing wrong with giving her antibiotics. She's going to need them. And it's going to take me some time to do what I really want to do, which is what? Try and get that tooth out. Try and relieve her obstruction. All right? How am I going to do that? Am I going to do that with an open thoracotomy? If you called, let's say on CSA, call a cardiothoracic surgeon, you might probably get 0 points. Because there's a rationale. Is this a patient who's going to need a thoracotomy? I don't know, maybe. Does it hurt to call a cardiothoracic surgeon? Doesn't hurt to call a cardiothoracic surgeon. If you said proceed directly to thoracotomy, -5. You say get a cardiothoracic surgeon to see the patient, 0, +1. Depends on what point in the history, in the case you're going to do something like call the cardiothoracic surgeon. If you do a history and a physical, and the first thing you do is call a cardiothoracic surgeon, you're going to lose points. Because obviously that tells the test makers at the USMLE, you haven't made the right diagnosis here. All right? So first you'll get the chest x-ray, you'll see her tooth sitting there. See your tooth sitting there, you want to get it out. How do you get it out? Hopefully you'll do it without cracking her chest wide open to take out this little tooth. You're going to do it by calling the pulmonologist, asking him or her to come with their bronchoscope, asking him or her to decide whether they think it should be a fiber optic scope or a rigid scope. That's up to them. This is not the pulmonary or cardiothoracic board. You want to call a pulmonary consultation, and if they don't give you that as a choice, a multiple choice, you'll say proceed with bronchoscopy. All right? CSA, if you write bronchoscopy, you'll get +5. If you write pulmonary consultation, you get +1. Pulmonary consult arrives, and a decision is made to proceed. What would be the next step that you should perform? Bronchoscopy. Why? Because you want to get that tooth out. You want to put a bronchoscope in, try and retrieve that, and take it out. Otherwise, the patient will not have relief of their obstruction, will continue to have their post-obstructive pneumonia. All right? You will not be asked, should it be fiber optic, should it be rigid? In a pediatric case, if they tell you, on the other hand, in a pediatric case, they tell you something seen on x-ray, very proximal, you'd want to put in a rigid scope. All right, because you can control the airway better with a rigid scope because, in fact, you could breathe somewhat. There's still some lumen through a rigid scope. You're putting a fiber optic scope. All you're doing is filling the lumen. You put a bronchoscope inside the lumen of the airway. Patient could still breathe through there. If you put a fiber optic scope, you're just plugging up the lumen. Why do we use fiber optic scopes? Because they're a lot more comfortable, and they could get down further. All right, they could get into bronchi far further than a rigid bronchoscope. But you don't have to worry about what kind of bronchoscope. You need to know that a bronchoscope is necessary here. Okay? All right. So we spoke about this patient, and we see on the x-ray, we see a small radiopaque density at the right mid-lung field, small infiltrate in the right lower lobe, distal to this region. All right mid-lung field. It sounds like I could probably reach that with a bronchoscope. And what I'll do is call pulmonary, have them come in, grab that tooth, and then give the patient antibiotics. Let's say you're still in CSA. You've done all this, and you're very proud of yourself because you ordered the chest x-ray, and it tells you the diagnosis. You say, yes, I'm on the right track here. You call pulmonary. The pulmonologist comes. You say, order bronchoscopy. Bronchoscopy is done. A tooth is removed. What do you do next? You say, hey, wait a second. I just made this brilliant diagnosis, 20-year-old. I don't usually think of foreign body aspiration, 20-year-old. I made a great diagnosis. I proved the diagnosis. I fixed the patient. I'm ready to go home. The question won't let up so easily. You say, what do you do next? All right? Remember, CSA could torture you forever. Or if you do so, you want to get out of CSA very quickly, drill a hole in everybody's brain the minute they come in. All right? That test will end very quickly for you. They'll say, thank you very much, please proceed to the next question. Or if you do it enough times, thank you very much, proceed to the next time we offer step 3. All right? Because you can kill someone very quickly, and the exam will become very short for you very quickly. But if you're managing a patient well, don't worry that the patient is going on and on and on. Doesn't mean you're doing something wrong. Okay? And at some point, and when you're watching this videotape, it might already have happened. CSA might score it based upon how well you did based upon how hard the question was. In other words, they might give you, and it's unclear whether this has already been improvised or will be improvised. All right, this is a little tip in terms of the test taking. You might find that you've had very hard questions, and the more you do for this patient and you think the patient's doing well, the harder it becomes. That might be a good sign, because the CSA has worked with computer software that is designed to challenge you more and more. In other words, if you're doing well and they think you could handle more difficult questions, they'll give you more difficult questions. If they see you're not doing so well, they're not going to jump from a simple question necessarily to a very hard question. They might give you a string of simple questions. You say, well, this isn't fair. The smarter I am, the more I'm being prejudiced against. In fact, if you answer the hard ones, you get a lot more points than answering the simpler ones. All right, so it works in your favor. So don't make a guess that just because it was so challenging that you don't know anything. It might be challenging because the boards recognize from your first few answers. This is really a very clever software that you're doing well, and they'll give you more challenging questions, all right, for which you'll gain more points. And whereas you answer all the simple ones easier, you're not going to end up with as many points, all right? And it's unclear when this will become a part of their testing and scoring, all right? But don't make an assumption, don't make any assumptions on the CSA based upon when the case ends. A patient might say, thank you very much, please proceed to the next case, because you killed the patient. Or because you decide to take a hot needle and put in the patient's eye, and the patient's left ankle sprain isn't getting any better. All right? On the other hand, you might have a patient like this, and you're doing well, you're doing good, you're doing good, you're doing good. Everything you do, the answer comes back from the computer that, yes, patient is improving, but they won't let go. Enough already. You want to go on. They say, what is your next step? Case isn't over yet. The next step here would be what? You got the tooth out, antibiotics. Very good. What do you do next? You you type in, admit the patient to the hospital. Okay, CSA, wide open. The possibilities are endless. So what do you do now? Question's not over. All right? Patient's feeling better after you move the tooth. Patient feels improved. Her respiratory rate comes down. What do you do now? You put her on antibiotics. What do you do now? Admit her to the hospital, admit her to the intensive care unit, let her go home with the pulmonologist. What do you do? I would say I would see her in the office. All right? When? All right? Schedule appointment for outpatient visit. Then you have to set the clock. When do you want to see this patient? Do you want to see the patient 6 hours from now? Do you want to see the patient 6 months from now? What's a reasonable amount of time? Sounds silly, but these are the questions that you're going to be asked on the CSA. Right? When do you want to see this patient? I say, again, there's a lot of correct possibilities. You want to see the patient 6 months, too long. If you want to see the patient 6 hours in the office, you're in the office, you want to see her 6 hours later, I wouldn't say you lose points. If you want to see in a day or two, that's okay. If you want to see it 2 weeks from now, that's too long. This was a patient with a foreign body obstruction. You want to make sure, in the next few days at least, that this patient is getting better, that the pneumonia is getting better. Okay? Everybody follow? Good. Free CSA, free, absolutely free CSA tips. Okay, so we talked about this patient's case. We talked along the way about aspiration pneumonia, how that would look. Okay? Aspiration pneumonia, I'm going to put it at the top of my list whenever I have a change in mental status and some new pulmonary process. For whatever reason, change in mental status, pulmonary process of whatever sort, think aspiration pneumonia. All right? Why? Because with the change in mental status, you lose your gag reflex and you start to aspirate. What will that change in mental status be? Could be anything. Could be you're drunk. Could be you're in the dentist's office, all right, as one of my friends claimed to have happened. He was in the dentist's office, had some major root canal work, got some intravenous Valium so he could sleep through all this drilling and extracting of his tooth. A day later, he had 103 and was coughing this putrid sputum. All right? And he said, oh, I know what happened. I aspirated yesterday while I was getting intravenous Valium, got a chest x-ray, had a big abscess in his chest. Within 3-4 days, a big abscess. Started pneumonia and got worse and worse. Maybe he was really drinking 2 days earlier and didn't tell us that part. But he claimed it was from his intravenous Valium, change in mental status, even for a short period. You could aspirate, and in fact, he did have a bad aspiration anaerobic pneumonia that eventually cavitated. So you can get quite sick pretty quickly from what seems like only a short period of a change in mental status. All right? Patients who go to the OR all have changes in mental status. All right? Major surgery, you better have a change in mental status while you're being operated on. You better be asleep and unconscious. Patients who have seizures have had a major change in mental status. Any of these patients develop pulmonary symptoms, aspiration pneumonia, should be on your list. It might not be the right answer, but it should be near the top of your list. A post-op patient who has change in mental, who has a pulmonary process, I have to worry about pulmonary embolus, lots of things I have to worry about. But aspiration should be near the top of the list. Okay, and we talked about as asthma. Can it be for 2 weeks? Sure. Can you develop a productive cough? You can. Can that give you a low-grade fever? It can, but do you have localized findings on exam from asthmatic bronchitis? No, it's a diffuse process. Anything that is focal, think about what is going on in that specific area. And as you know, asthma, you will have a more diffuse evidence of bronchospasm. On to the next case. Chief complaint, I have blood in my stool. History and physical. 76-year-old white man comes to the emergency department after passing stool that was surrounded by a large volume of blood. Okay, so we're talking about a GI bleeding case. This was CCS. I said this might be acute, maybe not so acute. The patient states he had 2 similar episodes 7 months ago but did not seek medical attention. He denies abdominal pain, fever, or diarrhea. He has a history of myocardial infarction and valvular disease. He is on no medications. Well, first of all, is this guy been well managed medically? Would you give points to his doctor? The guy has had a myocardial infarction, is on no medications? No. I mean, you should be thinking about what medications he should be on. After a myocardial infarction, certainly at the very least, what should he be on? Aspirin and beta blockers, okay? So this guy's been poorly taken care of. Vital signs are temperature of 37, blood pressure is on the low side, pulse is 100, and respiratory rate is 16. There are orthostatic changes. His abdomen is soft and non-tender. Rectal examination shows no hemorrhoids, no stool, but there is bright red blood in the rectum. Cardiovascular examination shows a 3/6 systolic ejection murmur radiating to the carotids. Do I know what that murmur is? Well, they tell me he has valvular disease. What kind of murmur is that likely to be? Aortic stenosis. Okay. What else would I like to hear about aortic stenosis? In general, I want to hear how loud is the second heart sound, right? The louder, the softer the second heart sound, the more severe the aortic stenosis, right? Because aortic valve, if it's very stenotic, instead of opening this far, where's my mic? Let's say that's the usual S2. Remember, most of S2 is comprised of A2 and not P2. So if this is my usual sound, because my valve is opening this much, and now if the valve is a little stenotic, it doesn't open this much, it opens this much, quieter. And if it opens very little because it's real stenotic, you don't hear S2. You hear, the question will tell you S2 is inaudible. Does that mean the patient is a unique medical creation? He only has one heart sound? No. S2 is inaudible because the aortic valve moves so little, because it's so stenotic, that there's very little blood flow across that valve. And if you don't have flow, you don't have a murmur. Okay? So that's something we're not told in this case. But after all, this is a GI case. I'm not so concerned about what valvular lesion it is. Although you're saying to yourself, well, isn't there an association between GI bleeding in the elderly and a particular valvular lesion? And that is aortic stenosis and what is sometimes called angiodysplasias. The other name for it is arterial venous malformations or vascular ectasias, all referring to the same thing. Vascular ectasias are probably the most politically correct term, because this is not an angiodysplasia. There's no dysplasia in these vessels, right? And it's not really, there's a malformation of the artery or the vein. There's an abnormal communication, an ectatic vessel between the artery and the vein, if you want to be very politically correct, all right? So vascular ectasia is the best term. Angiodysplasia is the worst term. Sometimes they're also called AVMs, arteriovenous malformations, okay? And they are sometimes associated with aortic stenosis. Does that mean that a patient with aortic stenosis on the boards that has lower GI bleeding automatically has vascular ectasias? Is there something about aortic stenosis that is preventive from every other form of GI bleeding? If you have aortic stenosis, don't worry, you're not going to die from diverticular bleeding? No. All right, so it might just be there to fool you. Aortic stenosis, you're very proud of yourself. You say, aortic stenosis, I recognize the murmur, lower GI bleeding, this is definitely vascular ectasias. On the other hand, they tell you the patient has a colonoscopy and there's a large fungating, massively bleeding tumor in the sigmoid colon. The answer is that's where the bleeding is from. Patients with aortic stenosis can have other causes of GI bleeding, but there is a reported association. Okay, so this case is going to talk to us about how we approach a patient with lower GI bleeding. What is your first step or the next step in the evaluation management of this patient? What's the answer? Make believe it's a multiple choice. The answer is going to be stabilize the patient hemodynamically. Put an intravenous in. Does this guy had a little bit of blood loss, moderate amount of blood loss, or a lot of blood loss? I put it from moderate to a lot. All right? It's not quite shocky, but he's orthostatic and tachycardic. All right? So this is not a trivial bleed. I want to put an IV in. All right? What else would I do? I'll send blood. What are you going to send blood for? If it's the CCS, send for type N cross. That's good. Get +3 for that. Send complete blood count. Okay, that's good. Send liver function tests. I say 0. Why liver function tests? You say, well, I always get liver function tests. Yeah, but is it necessary that you always get liver function tests, or is it doing it because that's the way things have been done, that you get a full panel on everybody who walks in? Liver function tests, I'd say you lose a couple points, actually. All right? No reason to get liver function tests on this man. If this was an alcoholic cirrhotic with lower GI bleeding, I'd say yes, get liver function tests. Confirm your suspicion that there is liver dysfunction. Confirm your suspicion that there's a coagulopathy, and I would get a proton and an INR. Am I going to leap to get a proton and INR in this patient? Do I have any reason to suspect a coagulopathy? I'd probably even take off a point. You say, wait a second, you GI bleeder, you're not going to check coags? Yes, I check them. I check them because that's been the tradition for 200 years. But the fact of the matter is, if I check an INR before I send the type and cross, that's the wrong thing to do. There's no history here of a coagulopathy. There's no history of this patient being on anticoagulants like Coumadin. All right? If this patient was on Coumadin related to their prior myocardial infarction, I absolutely would get an INR as my most important blood test. But a patient who doesn't have a known coagulopathy, who is not on anticoagulants, there's no real reason to jump and get a ProTime or a PTT. Okay? What else will I do in this patient? Order EKG. That's a good idea. Patient had a myocardial infarction. They're hypotensive. You'll get a couple points for that. All right? What do you do now? You've done all the things you could do to stall on the CCS. Put in the IV. That's always good. Start intravenous fluids. That's good. What kind of fluids would you start, by the way? Remember, make believe you're the intern. Make believe you're sitting in front of the computer on the CCS. You got to type something in. Insert intravenous catheter. Done. What kind of fluid do you want to order? D5, D50, D10, 5% dextrose, 10% dextrose, 50% dextrose? No. I mean, it's okay to give the patient some sugar. It's very sweet of you. Ha, ha, ha. But what you want to do is give normal saline or lactated ringers to supply intravascular volume, right? D5W, 5% dextrose in water does not replete the intravascular volume, okay? So you're going to give some form of saline to the patient. Now, let's talk about the evaluation of the patient with lower GI bleeding. First of all, I called this guy repeatedly a lower GI bleed. Does this guy have a lower GI bleed or an upper GI bleed? I don't really know yet, right? What are the causes of a lower GI bleed? And forgive me if I don't list them in exactly the same order as the syllabus, but you'll get the same message. What are the causes of lower GI bleed? Again, think what happens commonly. In an elderly, diverticulosis. If this was a 36-year-old, no, let me make it, a 26-year-old presenting with this exact story, is diverticulosis going to be number 1 on my list? Probably 10 or 15 on my list. Okay? From the elderly, diverticulosis. What's next? Vascular ectasias should be number 1 or number 2 on my list. Here I got the added piece of information that the patient has aortic stenosis. Maybe that makes me think of this a little bit more likely. But again, the patient can still certainly have diverticulosis. What else could this patient have? Well, this patient can have an upper GI bleed. Let's say the patient has a massively bleeding ulcer. Let's say I told you the patient was taking aspirin. All right? Can he have developed an ulcer and have so much bleeding that the bleeding is passing through the GI tract so quickly that it's presenting as bright red blood per rectum, hematochezia, even without vomiting or coffee grounds? Is that possible? Yes. And that's why somewhere along the way in the early assessment of this patient, I might put down a nasogastric tube. Because if that shows me fresh blood, I'm going to forget about colonoscopies and sigmoidoscopies and nuclear scans. I'm going to do what test if I get back blood? I'm going to do an upper endoscopy immediately to assess where the bleeding is coming from and to treat it. Okay? What else? What's going to cause bright red blood? Hemorrhoids. Does hemorrhoidal bleeding usually produce hypotension and shock? No. Usually it's some blood on the tissue, blood in the bowl. Remember, just a few drops of blood will turn the whole bowl red. Right? So that people often overestimate how much hemorrhoidal blood loss there has. But this guy clearly has had significant blood loss. He's orthostatic, hypotensive, and tachycardic. So if this is a hemorrhoidal bleed, it's a big hemorrhoid. All right? A real big hemorrhoid. Okay? And I will often know that just by external examination, but remember you could also have an internal hemorrhoid that you're not seeing, and all you're seeing is fresh blood when you're doing the rectal exam. What else? Someone mentioned ischemic colitis. Now, why should I at least think of ischemic colitis as a possibility? Because he's old and he has other evidence of ischemia. He's had a myocardial infarction. He has atherosclerotic vessels here. Maybe he has atherosclerotic vessels here in the left side of the colon. What is against the diagnosis of ischemic colitis? What am I missing to give me the idea of ischemic colitis? I'm missing pain. I'm missing signs of itis. Okay, I'm missing fever, tenderness. All right, I'm missing a history of diarrhea. Can you have ischemic colitis? Painless bleeding? Yes, but again, it becomes less likely than these. If I told you he had tenderness on exam in the left lower quadrant, or diarrhea for a few days preceding this, I'd say ischemic colitis is the best choice. In our particular patient that we're discussing, ischemic colitis should be on the list, but lower down. What else? Can they have colon cancer? Yes. How often does colon cancer present with a massive GI bleed or substantial visible bleeding? Infrequently. All right? More commonly presents with an iron deficiency anemia as a sign of continued or constant obscure blood loss, or it might present as low-grade or even high-grade bowel obstructive symptoms. Rarely presents with bright red bleeding. All right? Polyps even less likely because they're usually not big enough to bleed in that way, but they can, etc., etc. We got the big ones, and I could generate a long list of things that are more far less common even, like, could this be inflammatory bowel disease? An acute onset in a 76-year-old? I wouldn't even put it on the board. I don't want to even make you think about acute onset of bleeding. This is a 26-year-old with acute onset of bleeding. 26-year-old, exact same history, acute onset of bleeding. Is ulcerative colitis or Crohn's going to be on my list? 2 bloody bowel movements in the last day? No. Inflammatory bowel disease, whether it's ulcerative colitis or Crohn's disease or Crohn's colitis, is not acute. Acute in terms of one episode just like that. It's going to be weeks or months or maybe even years. Well, you might go back and say, well, this guy had a couple of episodes several months ago. Could that be the sign of chronicity? It can. But again, it's usually not one episode and then you're normal. It's usually building in intensity. And again, this guy is 76, not 26. Ulcerative colitis and Crohn's, when does it tend to attack? Teens, 20s, 30s. Right? By far, the vast majority of patients will have it in the teens, 20s, and 30s. Okay. Now, there's actually a typo in the syllabus where it says diverticulitis. That is wrong. Now, can you put it in your differential diagnosis? Sure, you could put that just like you put ulcerative colitis and Crohn's, which I said is not likely. But what we really mean to have in that differential diagnosis is diverticulosis. Okay? Diverticulitis means there's inflammation in the diverticulum, which causes usually a local perforation. So you have local tenderness, fever, and signs of itis. Fever, tenderness, leukocytosis. Does diverticulitis bleed? No. Okay? Can diverticulitis be very severe? Sure. Patients could go for surgery. Patients can even die from an acute episode of diverticulitis if they perforate freely into the peritoneum. But it doesn't bleed. Diverticulosis means the presence of diverticuli, and there could be a small arteriole in the dome of the diverticulum. If this is the diverticulum, I have a little arteriole here, and the bleeding comes from that single arteriole and is usually fresh, bright red arterial blood. Is that painful? Is diverticular bleeding painful? No. Is diverticulitis painful? Yes, because there's itis, but does diverticulitis bleed? No. All right? So diverticulosis is definitely on my list. Vascular ectasias. Is that on my list? Sure. Okay? These abnormal blood vessels, what do they look like? I doubt they would show you a sigmoidoscopic picture or a colonoscopic picture and say the following is seen, what is it? But basically, think of it as looking like spider angiomata that you see on the skin of a cirrhotic. That's what they look like in the bowel. It's right on the surface of the bowel. They're not hard to see. They're right there. If it's an upper GI bleed, I'll know that from my nasogastric tube. Hemorrhoid, I'll know that by either my external exam or putting a scope in. Now, an ischemic colitis, colon cancer, polyps, we think these are less likely. So what will be the appropriate test in terms of diagnosing this patient? Here, actually, we have several options which I think are correct. You could say, well, I'm in the emergency room with this fellow. He's not well prepped. I'll do a flexible sigmoidoscopy. All right? I think that's a very reasonable first choice and probably the best choice. If you say, well, why don't we go straight to a colonoscopy, I could give you arguments pro and con. So I doubt you'll be asked, and I'm a gastroenterologist, so I can really go into great detail, but I want you to know that the people writing this test will not ask you to choose between a sigmoidoscopy or colonoscopy, because even gastroenterologists, good gastroenterologists could differ on this. What they'll want you to recognize is that you need to put some kind of scope in to make a diagnosis. You will not send the patient for CAT scans, for barrier enemas, for angiograms, nuclear medicine scans as your first step. Your first step is to directly visualize the colon, and if you want to start by doing a sigmoidoscopy because that's available within minutes, and might show you a hemorrhoid that's bleeding, or might show you sigmoid diverticulosis that's bleeding, I will tell you that that's absolutely appropriate. If you say, well, I want to see the entire colon, let me put a colonoscope in and look throughout the entire colon, I can't argue with that. However, against that, the con for that is you have a patient who's not well prepped. But you could say, well, if he's bleeding actively, blood acts as a cathartic, he might be well prepped. The answer is you could start with a sigmoidoscopy because right then and there, it'll tell you if there's hemorrhoidal bleeding and you'll exclude that possibility. You'll be able to see into the sigmoid colon, and if you see many diverticuli with fresh blood welling up in an area of diverticuli, that gives you a very good diagnosis, okay? So the first test will be an endoscopic examination of some sort. I'm using endoscopy here in the largest sense. I'm not talking about an upper endoscopy. You're going to look inside, sigmoidoscopy or colonoscopy. Now, colonoscopy will also allow you to see vascular ectasias. Why will you usually not see vascular ectasias with your sigmoidoscopy? Because how far does the sigmoidoscope go in? Well, the sigmoidoscope goes in small bowel. Okay? Your sigmoidoscope usually goes in about this far or this far through the sigmoid colon. If you're really good at it, you can get a little higher into the descending colon. Where are diverticuli usually found? Sigmoid colon. Where are vascular ectasia usually found? Cecum and right side of the colon. All right? So if I did a sigmoidoscopy in this particular patient, and I saw, the question says internal hemorrhoids, non-bleeding internal hemorrhoids are found. Okay, not the source. Diverticuli are seen without any blood in the area. That doesn't sound like a diverticular bleed. Or they say there's blood, but there's blood coming from a more proximal region. Your sigmoidoscope only gets up to here. At that point, you could start suspecting that the patient has vascular ectasias because you've seen the area where there are the most diverticuli. Or they tell you the sigmoidoscopy is normal, no diverticuli found. You know for sure what would be your next test then. Then I would do a colonoscopy because then I'll be able to get all the way around. You say, well, colonoscopy, patient's not prepped. You have to spend an hour or two at least prepping the patient. Colonoscopy also allows me, besides diagnosis, will allow me to treat the patient because the treatment of vascular ectasias is to either cauterize them or burn them with various modalities. You're not going to be asked whether you use heat or electric current, whatever. You need to know that it is treated endoscopically through the scope. Okay? So a sigmoidoscopy might give me the diagnosis right away, and I could do that right away. So I would say I would give you points for that. All right? If that shows you the diagnosis, then you deal with the hemorrhoids. You would band them. If you have a diverticular bleed, you say to yourself, what's the natural history of diverticular bleeding? Most stop on their own, so you'd observe the patient. If they rebleed, you have to think about whether you're going to operate on that patient to resect that segment. Okay? And if you do a sigmoidoscopy and you don't see either of those, and you also don't see, say, ischemic colitis, which is most frequently involves what part of the colon? mid-rectum, and splenic flexure, the watershed areas. So if you see no evidence of ischemic colitis, certainly your most likely diagnosis will be vascular ectasias. Okay? Now that's assuming you've already excluded the possibility of an upper GI bleed by putting down a nasogastric tube. All right? Because let's say I do my colonoscopy. It says the colonoscopy is done. The entire colon, the lumen of the colon is filled with blood. No specific bleeding site is seen. What is the diagnosis? The diagnosis is I don't know. All right? Often the colon is so full of blood you can't see the walls very well because all you're seeing is blood everywhere. And let's say you put the scope into the small bowel and you see blood coming from higher up, from above, then you know it's an upper GI bleed. Okay? And then certainly the next test in that situation would be an upper endoscopy. All right? But remember, an upper GI bleed can present with what looks like a lower GI bleed. But if that is the case, what kind of upper GI bleeds present with lower GI bleeding? In other words, with hematochezia. A little trickle of blood or a torrential huge bleed. Torrential huge bleed. So it is not consistent in a patient who has bright red blood per rectum, who is hemodynamically stable. It is not consistent to blame that bleeding on upper GI bleeding. Because when upper GI bleeding presents with hematochezia, that is a big bleed, and if you're making that diagnosis, make sure that patient is hemodynamically unstable in the question. Because if you've got a hemodynamically stable patient with bright red blood per rectum, that's not consistent with an upper GI bleed. Okay, everyone follow that logic? Now, one more point that I want to make about distinguishing upper GI bleeds from lower GI bleeds is there's one more trick you could use. Simple trick. And you'll already have the information back by the time you finish your sigmoidoscopy. And that is serum electrolytes. Serum electrolytes? I thought you were going to say the CBC. The CBC doesn't help you. This is a big bleed. This man could be severely anemic from either upper or lower. How does electrolytes help me? Well, you use the BUN creatinine ratio trick. The BUN creatinine, we already mentioned BUN creatinine can be elevated above 20 to 1 when the patient is dry. Will this patient be dry? Yeah, sure he'll be dry. He's losing exactly what fills your blood volume, blood. All right? But he'll be, so the BUN creatinine will be greater than 20 to 1 for sure. Okay? But if it's greater than 40 to 1, that is very suggestive of an upper GI bleed. All right? So if the creatinine is, let's say, 1.1 and the BUN is 50, yes, of course, he's pre-renal. It's greater than 20 to 1. But this BUN to creatinine ratio tells you something else. This patient has blood that is circulating through the GI tract, and blood has blood, urea, nitrogen, right? That's what the B in BUN stands for. And as it's passing through the small bowel, the blood can be absorbed and metabolized to BUN. And your BUN goes up way out of proportion to your serum creatinine. So a very elevated BUN creatinine ratio, greater than 40 to 1, is very indicative of an upper GI bleed. Okay? Now, let me just mention, and they'll never be the first step, the concepts of diagnosis using a nuclear scan or an angiogram. A nuclear scan is where I will inject the patient's bloodstream with a radioactive label that I can then follow on a nuclear scanner for up to 24 hours. So let's say I put the scope in, sigmoidoscope, all I see is blood. I then do a colonoscopy, all I see the entire colon is blood. I've had a nasogastric tube that is negative, just shows clear bilious return. So now I'm dealing with something in here that's bleeding, but I have no idea. And to make it matters worse, this area has lots of diverticuli, but there's so much blood everywhere, I can't see a single diverticulum bleeding. There's usually a single tick. What do I do then? Well, then I would do a nuclear scan, because that allows me to see where in the colon is the blood coming from. If I inject you with the contrast that will show up on your red blood cells, and now you're bleeding, those red blood cells, when you do a nuclear scan, you basically should see an outline of the vascular anatomy. You should see aorta, iliacs, etc. You shouldn't see blood pooling outside of a vessel. And if on a nuclear scan, you see blood pooling here in an area of diverticuli, that's telling you it's a diverticular bleed. Okay? Does it allow you to do anything therapeutically? Of course not, but it gives you the exact location, or at least a general target. If a bleeding scan does not show you the place, and the patient continues to bleed, then I would consider doing an angiogram, which is a far more invasive test, okay? And the patient has to have a catheter placed in a large vessel, and then we will inject that vessel and see where blood is coming out of. It's an invasive test. It does allow us to treat, because if it is a diverticular bleed, we can occasionally, we will try and vasoconstrict that specific vessel, all right, which is not done commonly, because if you start vasoconstricting through an angiographic catheter, what's the problem? You're going to vasoconstrict that vessel, but you're worried about you're going to vasoconstrict adjacent vessels and cause ischemia. Or if you have a vascular ectasia on the right side of the colon, an angiogram could see that. But that would be my last test. I can't think of a case where an angiogram would be my first, second, or even third step in the diagnosis of a lower GI bleed. First will be either sigmoidoscopy or colonoscopy. If they give you some elevated BUN creatinine ratio, you're going to have that nasogastric tube in right away. You'll see blood, and you'll do an upper endoscopy. If you've done your sigmoidoscopy, you don't see anything, you'll do a colonoscopy, see the rest of the colon. If you see everything filled with blood and no active bleeding, I'd go to a bleeding scan.